This chart contrasts the healthy, dynamic response of endogenous insulin secretion on the left against pathological states on the right. In a healthy pancreas, insulin spikes precisely in response to fluctuating glucose levels, maintaining tight glycemic control. Look at the flat line in the right panel. In type 1 diabetes, the beta cells are destroyed, resulting in an absolute production failure and a complete absence of endogenous insulin. Directly below that is the blunted, delayed curve characteristic of type 2 diabetes. Here, the body produces insulin, but peripheral tissues resist its action, and the output is ultimately insufficient to overcome that resistance. The primary goal of exogenous insulin therapy is to intervene in these exact pathologies by structurally replacing or supplementing the missing endogenous hormone. Pharmacologically, introducing this exogenous hormone executes two immediate mechanistic functions. It forces peripheral glucose uptake into muscle and fat tissue while actively reducing hepatic glucose output from the liver. It also triggers critical secondary metabolic functions. A steady presence of insulin suppresses ketone production and drives the synthesis of macromolecules, including glycogen, fat, and protein. Because the drug itself reliably drives these pathways, the entire utility of any specific insulin preparation is dictated purely by its pharmacokinetic engineering, specifically how quickly it acts and how long it lasts in the body. Restoring true metabolic control requires matching the exact biological timing of the missing endogenous hormone. Failing to perfectly mimic that timing leaves the body vulnerable to catabolic breakdown. This graph maps a standard 24-hour cycle, plotting exogenous drug action against distinct mealtime and fasting states. Rapid-acting insulins like Aspart and Lispro create a sharp, narrow peak, working within minutes. Clinicians utilize this immediate onset by having patients administer rapid-acting preparations precisely around meals to intercept severe spikes. Short-acting or soluble insulin provides a slightly wider, delayed peak. Its onset is noticeably slower. Because of sluggish absorption, short-acting insulin is dosed earlier before meals. To bridge the gaps, intermediate-acting insulin provides a broad, rolling curve. Long-acting basal insulins stretch that profile further, creating a flat, continuous horizontal line across the entire 24-hour axis. This prolonged profile provides steady background control. By combining the continuous basal line with rapid mealtime peaks, clinicians construct a basal bolus regimen. Biphasic insulin physically combines mealtime and background profiles into a single fixed mixture injected at once. While this composite approach reduces injections, it strictly limits dosing flexibility. If a patient skips a meal, the fixed background dose cannot be easily adjusted. Structurally altering these insulin molecules at the manufacturing level allows clinicians to synthetically recreate the precise, dynamic metabolic control of a healthy pancreas. This matrix links specific patient populations to the required pharmacokinetic models. In type 1 diabetes, the pathway leads directly to the comprehensive basal bolus regimen. Because type 1 patients lack any endogenous production, replacing the entire 24-hour cycle is an absolute necessity. Following the type 2 pathway, the initial strategy changes. Insulin is not first line for type 2 diabetes. It is an escalating adjunct introduced when oral therapies fail or when severe catabolic symptoms present. The matrix points directly to a basal-only regimen. If that flat basal coverage provides poor control, the regimen escalates, adding rapid mealtime spikes to handle resistance. In gestational diabetes, the matrix maps out a specific use case. When lifestyle measures fail, insulin is deployed because it reliably forces glucose down, and its large molecular structure prevents it from crossing the placenta. The severity and exact mechanism of the metabolic failure dictate the clinical response. Total beta cell destruction requires a full physiological simulation. Long-term outpatient management relies on the predictable, slow-release absorption of subcutaneous injections, but acute inpatient care operates on a high-stakes, hour-by-hour timeline. When severe metabolic stress occurs, clinicians utilize a variable-rate intravenous insulin infusion, or VRII, injecting insulin directly into the vein. This immediate route overrides the slow subcutaneous absorption curve, providing an instantaneous physiological effect that clinicians can titrate and adjust hour by hour. This immediate control is indicated during acute inpatient illness, periods of starvation, or complex perioperative care, where standard subcutaneous regimens become temporarily dangerous or unsuitable. To prevent profound hypoglycemia, strict protocols require that VRII is continuously paired with intravenous substrate fluids to provide a steady supply of glucose. Crucially, a patient's usual long-acting subcutaneous basal insulin must almost always be continued alongside the intravenous infusion. If a clinician abruptly stops basal insulin while treating an acute event, the patient lacks background coverage, risking severe rebound hypoglycemia and rapid ketosis. Acute metabolic decompensation strips away the luxury of time. Clinicians must abandon predictive curves and take direct, real-time control through intravenous intervention. Pushing glucose rapidly into tissues comes with a severe systemic risk. Hypoglycemia is the most immediate and dangerous complication of exogenous insulin therapy. This flowchart tracks how the risk of profound hypoglycemia increases when insulin is combined with other glucose-lowering drugs, particularly sulfonylureas, which independently force the pancreas to secrete even more insulin. Beta blockers introduce an entirely different mechanism of danger during a hypoglycemic event. By blocking sympathetic nervous system receptors, these drugs mask the classic adrenergic warning signs of low blood sugar, such as tremors and palpitations, leaving patients entirely unaware that their glucose has dropped to critical levels. On the counter-regulatory side, corticosteroids actively raise baseline blood glucose, meaning patients prescribed both drugs will require significantly higher doses of insulin to maintain control. Beyond glucose, this cellular model shows an insulin molecule binding to a surface receptor. This action triggers a secondary metabolic pathway that targets electrolytes. As insulin forces glucose into the cell, it actively drives potassium ions from the extracellular space in alongside it. Because of this aggressive shift, high doses of intravenous insulin cause serum potassium to plummet, making strict electrolyte monitoring an absolute requirement during acute IV therapy. These complex systemic effects amplify a final practical prescribing danger. Different insulin strengths, brands, devices, and formulations are not automatically interchangeable. Clinicians who assume a long-acting brand can be seamlessly swapped for another, or fail to verify the exact concentration of a pen device, routinely cause major dosing errors in clinical practice. Mastering exogenous insulin means calculating exactly how quickly a preparation works and precisely how long it lasts. You match that pharmacokinetic curve to the specific pathological deficit, while rigorously monitoring the severe drug interactions and cellular electrolyte shifts it triggers throughout the system.